A and P. It's good for you and me. Okay, my friends, here we go. We're going to cover the appendicular skeleton, also articulations and body movements. And here we've got this freaky contortionist, obviously has some high-grade elastic fibers at his disposal, and looks painful, but he's got a smile ear to ear. So don't try this at home. Learning objectives. Hey, know the elements of the appendicular skeleton, be able to describe what comprises a joint, be able to distinguish between a male and female pelvis, and what happens when joints, bones age. And we're going to talk about some select joints towards the end of the presentation. So here we go. Now, everything that is in tan or pinkish, that is going to be the axial skeleton. Say it with me. Skull, spine, thoracic cage, sternum, hyoid, auditory ossicles, or the ear bones, which we will cover at a later date. Everything else is going to be the appendicular skeleton, specifically the girdles of the body. So, get my marker out here. The shoulder girdle is otherwise known as the pectoral girdle, and we've got the pelvic girdles right here. So these girdles, they act as like harnesses that attach the extremities to the body. There's the upper extremity, lower extremity. The pectoral girdle is comprised of the scapula. That's a triangular shaped wing that we all have two of on the back of our thorax. And then the scapula is going to be attached in the front to the clavicle or collarbone. There's a joint called the acromioclavicular joint, or the AC joint, that is going to be right here, the joint between the scapula and clavicle. Of course, the clavicle is in turn going to move medially and attach to the manubrium of the sternum, where we've got a sternal notch, or clavicular notches on the lateral aspect of the sternum. As stated, the upper extremity, the upper limbs are referred to as the extremities. There are approximately 30 bones in the upper extremities, and the primary bones are the humerus, the ulna or your elbow bone, your radius or your thumb side. Your wrist bones are called your carpals. The long bones inside your palm are the metacarpals, and then your fingers are your phalanges. The humerus kind of makes me want to chuckle, you know. It's a long bone, so therefore the shaft is termed the diaphysis, and the head is called the epiphysis. The humerus has a roughened area over here where the deltoid muscle, big, powerful three-bellied muscle has three parts. What I mean, there's an anterior, middle, and posterior deltoid, and that attaches right here. And you can see on the best of the humerus specimens, there'll be a roughened out, raised area that the deltoid attaches, called the deltoid tuberosity. The inside and outside of the brachium in anatomical position, you can palpate the epicondyles, the medial and lateral epicondyles. And then there are some other structures that help receive the ulna and the radius. We're talking about the trochlea and the capitulum. Here's a lateral view. The humerus coming down from above. And we've got the radius. It's got a feature called the radial head that spins on the capitulum. It allows you to pronate and supinate, as we conducted in class. The elbow bone, or the ulna, has a sharpened hook that kind of wraps around. It's shaped just like that, and that attaches to your humerus and rotates. So this is the angle, rotates about this axis here. All right. And on either side of the distal aspect of the humerus, there are these sharpened pieces, like the olecranon process and the coronoid process, that are going to be received into the humerus. These are the coronoid fossa and the olecranon fossa, respectively. Here's an interosseous membrane that is a fibrous joint that holds these long bones together, the radius and the ulna in the lower extremity, the tibia and fibula. Carpals, metacarpals, and phalanges. These are the wrist and hand bones. There are 1, 2, 3, 4, 5, 6, 7. Yeah, there are 8 carpals. They're like these little roundish bones that make up your wrist. They're all attached together by carpal ligaments or intercarpal ligaments, and so they're held together, and they perform different functions. They help facilitate movement at the wrist and some flexibility. I mentioned the mnemonic "some lovers try positions that they can't handle." That stands for from the thumb side. There's the scaphoid, the lunate, the triquetrum, and that ball that we palpated in lab called the pisiform. Some lovers try positions. That, trapezium. They, trapezoid. Can't, capitate. And handle, hamate. We're going to review that in lab very, very well. We'll cover that in lecture when we do our review next week as well. Some lovers try positions that they can't handle. And that's our acronym for the carpals. And then the metacarpals are the long bones of the palm. They're numbered 1 through 5 from the thumb side. The fingers attached from the phalanges are the fingers. They attach from the metacarpals. And there are proximal, middle, and distal phalanges. So it's important to know the difference between them. Where the metacarpal, let's say where the second metacarpal attaches, or the second ray here of the hand, second metacarpal attaches to the proximal phalanx, and the middle or intermediate phalanx, and the distal phalanx of the right second digit. It's a lot of information, right? Pelvic girdle. Now we're looking at the lower extremity. We talked about how the sacrum is a large triangular bone. And the sacrum is known as the keystone in physical medicine, the keystone of the body. In other words, if your sacrum and if your pelvis is level, then everything else is going to be level. But if your pelvis is twisted out of whack, then you could have mechanical problems, and you could see declining function or uneven wear of joints, back pain, sciatica, things like that. So we run into that a lot, and a good deal of my day is about taking people, removing pain, restoring mobility to people's spines. So, sacrum, various features of the sacrum that we will cover in lab. The sacrum in the middle, the keystone of the body. We've got these other 2 structures that attach to either side, and these are the os coxae or the innominate bones. All right, whichever one you can understand better. There are 3 parts of those innominate or os coxae bones. This one up top with the big blade that you can put your thumb on top of, feel it just above your belt line or below your belt line, is going to be the ilium. And then this thick roughened bone we sit on, rounded, it's called the ischium. And then the pubic bone meets the other pubic bone in the center. There's a piece of fiber cartilage, the pubic symphysis, right in the center. This is the pelvic brim. It's a breakdown of the os coxae or innominate bone, ilium, ischium, pubis. Note that there is they call it a triumvirate cartilage before skeletal maturity. These three bones, they form. So they meet in the middle of what's called the acetabulum, which is the hip socket. And those three bones will fuse once they're fully developed to create this hemipelvis. By gender, the male pelvis is going to be, the bone is going to be bigger and stronger. There's also going to be a change in the angle of the pubic arch in a female. Female bone structure will be thinner, and there'll be a larger pelvic brim, be wider, let's say wider hips, right, for women. So you should be able to identify that. I'm going to find some good images and hopefully a comparative structure in the lab so we can check out the dimensions of the pelvic basin here that is going to be larger in the female. Lower limb comprised of the femur. We reviewed this in class today. The femur is the longest, strongest bone in the body. At the end of the distal femur, right, we've got two condyles that sit on top of the shin bone or tibia. Between the femur and the tibia, we've got your kneecap or your patella. The anterior aspect of the shin bone is going to be sharp, and at the medial aspect, it's going to terminate in the medial aspect of the terminal tibia. Distal fibula is the medial malleolus. You'll feel that on the inside of your foot, the medial aspect of your ankle. The long, thin bone fibula, fibular head at the top, up by the tibial plateaus, and then it will reach the distal end, and you'll feel that lateral malleolus. The tibia and fibula will form what's called the mortise joint and attach over the most superior bone in the foot, or largest, one of the biggest tarsals we have is the talus. We're going to talk about that in a second. So the femur, as mentioned, long, strong bone. Femur is going to articulate in that acetabulum. It's going to join the acetabulum, as we mentioned previously. Femur is a long bone, so it's got a head, neck, and shaft, or a epiphysis, metaphysis, and diaphysis, respectively. A large, palpable bone on the outside of your hip is the greater trochanter. It's a muscular attachment site. On the inside, just catty corner to that, is going to be the lesser trochanter. And there are two condyles that are at the distal femur, and they are going to facilitate movement at the knee joint. Patella is a sesamoid bone, or a bone that develops within a tendon. It provides mechanical advantage. On the back side of the patella is hyaline cartilage, which is going to provide cushion and lubrication. A clinical condition that you will run into when you guys are practicing is chondromalacia patella, where the underside of the kneecap that is lined by cartilage has been scratched away, irritated, inflamed, just due to overuse. So that can be very painful. The tibia and the fibula are adjacent one another, form the lower leg, or the crural area. We've got the tibial plateaus on which the femur sits, as stated. We've got an interosseous membrane that attach, it's a fibrous joint that attach the tibia and fibula. Tarsals are the ankle bones, the largest of which is the heel, or the calcaneus. The superior aspect of the calcaneus is going to come together with the talus, and the talar dome is what the tibia and fibula are going to come down and rest upon in the mortise joint. The long bones of the foot are going to be termed the metatarsals, as opposed to the metacarpals. in the hand, and they are numbered 1 through 5 from your hallux, or your big toe, to your pinky toe. Want to take note, be reminded that there's significant load or force that is borne on the talus and the calcaneus, tarsals in specific, and that there's a lot of your combined force from your glutes and your pelvic muscles, thigh muscles, are going to be focused at the tip of your big toe when you walk. So the other tarsals are about transferring force to that big toe. Good depiction laterally of the tarsals and metatarsals. Here's the talar dome that we mentioned, and that's where the tibia and fibula are going to attach to. Here, this big bone on the bottom, biggest tarsal, is your heel bone or your calcaneus. And the other tarsals that you're going to have to memorize: metatarsals, phalanges, are the same structure and function mentioned in the phalanges in the hand. Proximal, middle, distal phalanges. Arches of the foot help dampen forces. There's a horizontal and a longitudinal arch. We talked about flat-footedness, high arches, plantar fasciitis, force dampening, leverage, footwear. Skeletal system is going to be derived from embryologically from the ectoderm. Joints are two bones coming together that are surrounded by a joint capsule. They're pulled upon by tendons, and they are lashed together by ligaments attaching bone to bone. There are different types of joint classifications. There's fibrous joints, such as that interosseous membrane that we mentioned, and sutures in the skull. Very strong joints. Also the gomphosis in your teeth, fitting into the socket. Those are fibrous, very strong joints, almost unmovable. Cartilaginous joints, such as the pubic symphysis and the intervertebral discs. Synovial joints, you need to remember that they are freely movable, and most of the joints of the limbs that facilitate locomotion are synovial. There are different functional classifications based upon degree of movement. Synarthroses are going to move barely at all, and those are, again, those skull structures, teeth sockets, symphyses. Amphiarthroses are going to move slightly, so the intervertebral discs and the pubic symphysis, the interosseous membranes. And then diarthroses are freely movable, that's shoulder, elbow, the main joints of locomotion. Example of fibrous joints and sutures and syndesmosis between the tib-fib, between the radius and ulna. Cartilage joints here, another type of cartilage joint is a growth plate. And we talked about the different zones of calcification: resting cartilage, proliferating cartilage, hypertrophic cartilage, and calcification, zone of calcification. Synovial joints, as stated, are surrounded by a joint capsule, synovial membrane. Synovial membrane is going to release synovial fluid, which is like an oil or grease. It's like oiling up a hinge with WD-40. So that synovial membrane is very, very important, and joint capsule keeps the joint together. We looked at our fingers and moved them and cracked them and demonstrated what the crack is all about. Creates distracting the two joint surfaces, decreasing the space and the pressure, and creating a vacuum. Here is, mind you, in the central aspect of the bone, you've got spongy bone and compact bone surrounding that. Synovial joints do have extensive nerve and blood supplies, but for their nutrition of the cartilage, remember that cartilage is oftentimes damaged in the case of arthritis, and that is about diffusion. Cartilage gets its nutrition by diffusion, as no direct blood supply. Different movements at synovial joints we enacted together: gliding, angular motion, rotation. Elevation and depression is like your jawbone. When you chew, protraction and retraction happens at the scapula, thoracic joint. When you round your back and pinch your shoulder blades back, as in doing our skydive. Inversion, eversion, you're standing and you're bringing the blade of your foot, the sole of your foot out, or in versus out. Plantar dorsiflexion happens at the foot. Supination and pronation. Remember, supination, it's like you're holding a bowl of soup, palm up, elbows bent, and then palm down. Opposition would be bringing your pinky or your fifth digit to your first, your thumb. Examples, diagrams of types of synovial joints. You should know if I tell you hip or glenohumeral, you should know that's a ball and socket joint versus the atlantoaxial joint in the spine, first and second vertebrae, cervical vertebrae. Hinge, elbow's a good hinge joint. Moving on to finish up with selected joints of the body. Your temporomandibular joint is the jawbone. This is where the condyle or the mandible is going to fit into the fossa of the temporal bone. Mandibular condyle, mandibular fossa. Muscles attaching to it. Notice we got a styloid process here with a stylomandibular ligament attaching. There would be all kinds of muscles lashing in here, glands around them. They're going to squirt saliva into the mouth, etc. Temporomandibular joint, or TMJ. Temporomandibular dysfunction is when people chew their food, or they grind their teeth, or they sustain an injury to the mouth or the jaw that causes a tracking disorder, pain. Glenohumeral joint is the shoulder joint. It is a ball and socket joint. It is a synovial joint. It has all those structures from cartilage lining, the hyaline cartilage lining the epiphysis, to the synovial membrane secreting synovial fluid, to capsules and ligaments attaching bone to bone, and the rotator cuff muscles stabilize the joint. It is the most mobile joint in the body, and it does that. In order to do that, it must sacrifice some stability, so it is subject to injury. But it is capable of 360 degrees of motion. Elbow joint is a hinge joint. It's between the humerus, ulna, and the radius. Here's the humerus coming from superior. Here's your elbow bone, or your olecranon process. We talked about that. We talked about the bursa, this blue collapsed balloon-looking structure there. If you hit your elbow firmly enough, you can inflame that bursa, which is designed to reduce friction. You'll blow it up and have a stupid-looking elbow. The radius attaches here. The radial head fits into the capitulum of the ulna, and the trochlea of the humerus is going to articulate with the ulna down here. Femoroacetabular joint, or your hip joint, is the strongest joint in the body. There is a ligament here that attaches the ball and socket joint of the hip. It's called the Y ligament of Bigelow. It's shaped kind of like a Y. A guy named Bigelow named it, and it's really strong. It helps to protect and hold the hip together. It's got a deeper socket. It's also a ball and socket joint, like the shoulder joint, but it's got a deeper socket. The acetabulum of the pelvis is deeper, so it tends to be stronger. You're not going to find people fracturing their hip too often, unless in the event of car accidents. However, a lot of hip degeneration, osteoarthritis, which also affects the knee. And here we've got the knee joint with the distal femur and the proximal tibia, fibula, patella, patellar tendon, or I'm sorry, quadriceps tendon, patellar tendon, You might have heard of cruciate ligaments or ACL, PCL tears in football and other sports. Cruciate means cross, so those ligaments will cross and hold together the knee, essentially internally. Also, the meniscus kind of looks like a bow tie from the front anyway, and the condyles of the femur are going to rest right in here. And that's going to help keep the knee nicely seated and protected as it comes together with the tibia. Joints age, here's a depiction of the distal aspect of the femur, the cartilage, the hyaline cartilage that lines the joint. It's scraped up, irritated, inflamed. These are those cruciate ligaments. The generation of knees, elbows, hips, weight-bearing joints are very common. New techniques to fix those problems. Here's a total knee replacement, titanium implant in the distal femur and the proximal tibia. Have a nice day.